honor to be here with you.
It's great to have you. It's our pleasure and privilege. Um, it's fabulous to have you. And
To be here with you.
it's great to have you. It's our so just getting all the things set up. I opened so many windows.
So Naren, if I understand well, I will leave the introductions to you.
Yes, if that's okay.
Yeah, sure.
And if you could then do an interrogation of the speakers and also share your experience or
No,
any.
no, no. Of course, I will intervene. But if you allow me, I will introduce you.
Brand new
Oh,
OS Ventura.
I'm just kidding. Oh, thank you. That will be very kind of you.
Okay, let's do that.
Thanks. Another 100 windows to close. Let's get there. That's my Zoom. Oh, good. I finally come to my Zoom. So that when you have too many monitors and windows, it's going to be fun. But I'll pull it down. Hello, Shalindra. How are you? And hello, Kenichi. Hello, Tobias. Hello, Arthur. Hello.
Hey, hello. Hello, Naren.
Nice to see you.
Yeah.
Hi.
Hello, Georgia. Yeah, nice to meet
Hi.
you. How are you?
I'm fine, thank you. Good to see you.
Yeah, good to see you.
It's hello, Tobias.
Hello. Hi.
Hi, Tobias.
Hello. Nice to see you all.
Nice to see you.
Great
Nice to see you.
Tobias, I know you know Giorgio. Do you know Kenichi?
No,
Yeah.
I haven't met Kenichi, but Giorgio, yeah.
Professor Kenichi Nishiyama, Kenichi, he's the head of neurosurgery at Niigata, so not far from Nagoya. And he is very, very active in hydrocephalus and particularly pediatric hydrocephalus.
Yeah.
The president-elect of the International INFE, International Neurosurgery, Neuroendoscopy Society.
Neuroendoscopy.
And so,
Thank you, Naren. Yeah, nice to meet you.
And,
nice to meet you, yeah.
And Dr. Tobias Langheinrich, he is a consultant neurologist at Salford Hospital in Manchester. I worked with him for 18 months. He runs the it's obviously a neurosurgery, neurology. It's a multidisciplinary team, but the heart of it is Tobias running the NPH practice. A really fantastic setup.
I see.
He and his neurosurgical colleague has set up. So it's really fantastic. So great to have you, Tobias. And hello, Shalindra.
Hi, Naren. Hi, everyone.
Hello. I'm very well, thanks. Shalindra, I know you're coming from the pediatric world. And can I introduce you to Giorgio?
Yep. Please.
So this is Mr. Shalindra Magdum. Shalindra, he's a consultant pediatric neurosurgeon in Oxford. His master surgeon spans the whole depth of pediatric neurosurgery, but his main interests are craniofacial tumor and hydrocephalus. And Giorgio Palandri, he comes from, I'm afraid, a university older than yours. Shalindra, he comes from Bologna.
Yeah.
And it's a beautiful, beautiful place. I bought a nice big book called The Beautiful Universities of the World. And I'll send you the link. It's Giorgio, I know him from the Hydrocephalus Society, a doyen of adult hydrocephalus, published high impact papers on every area of hydrocephalus, but more than that, he's a really lovely human being.
Oh, thank you.
And which really makes it he's very very positive, encouraging juniors, seniors, and so it's great to have him. And I'm sure you know Kenichi Nishiyama. He's at Niigata, the chair there, and also the president-elect of the International IFNE, International Federation of Neuroendoscopy, extensively published in hydrocephalus. And Tobias is from Salford. I worked with him when I was in Manchester, consultant neurologist. So he's going to give us the secret about differential diagnosis of NPH. Tobias, as you know, is from Germany. Is it Düsseldorf, Tobias, you're originally from?
No, I was born in Ulm.
Ulm, yes, you did from Ulm, but he's now a true Mancunian, and obviously Professor Henry Schroeder is here. Hello, Professor Schroeder. Lovely to meet you. I'm sure you all know Professor Schroeder. So Professor Schroeder, your compatriot Tobias Langheinrich, he was my when I was in Manchester, he was my neurology colleague, and he's a consultant neurologist dealing with adult hydrocephalus, and who's the heart of the practice. So, so thank you very much to all of you for coming to this meeting. And I think we are probably just on time or just over time. So, so we'll start. I'll do the welcome, and then we will go in the order of Dr. Tobias Langheinrich, because he's our guest coming from the neurology world, and then Professor Schroeder, and then it will be me. So thank you very much to everyone for attending this fourth hydrocephalus, pediatric and adult hydrocephalus webinar. We really have an excellent program. I think you will hear from some leaders in the field, and covering a wide spectrum. And also we have got a amazing panelist, very senior panelist, who hopefully will interrogate the speakers on behalf of you. But please, if you have any questions, please put your questions on the chat box. And also to give their insight, the combined insight of George, Professor Giorgio Palandri, Professor Nishiyama, and Mr. Shalendra Magdum in itself will be at least 100 years. So, we have a great team. I just want to introduce the panelists first, and then we'll go to and then I will introduce the first speaker. So the first panelist is Professor Nishiyama. I'm introducing them from east to west. Professor Nishiyama is the professor and chairman of neurosurgery at Niigata. He's published very high impact papers on hydrocephalus, and he's a master of neuroendoscopy and president-elect of the International Federation of Neuroendoscopy. I had the privilege of meeting him through introduction by Mr. Richard Edwards for the symposium I organized in honor of Dr. Goodrich, with whom he was very close to. And I have since met him in a couple of conferences, and he has given us lectures at our webinar. So thank you, Professor Nishiyama.
Thank you, Narendra. It's a great pleasure to be here, and I want to enjoy it this night. Thank you.
Thank you so much. Thank you. Then the next of our expert panelist is Professor Giorgio Palandri. He is from University of Bologna. As you will know, that is the oldest university in Europe, obviously 1,000 years later than India, but oldest university in Europe. Beautiful, beautiful place. I'm buttering up so that one day we will actually have a proper feet-on meeting at his beautiful university. He's a doyen of adult hydrocephalus. He's published high impact papers which have influenced practice in adult hydrocephalus. He is in the heart of the International Society of Hydrocephalus, and it's a real honor to have him with us. Thank you, Professor Dr. Palin Derry.
Thank you very much, Naren. The honor is truly mine.
Thank you so much. And then we have now to UK, to the west is Mr. Shalindra Magdum. Mr. Magdum, I had the honor and privilege of working with him for the time I was in Oxford. He's a master surgeon. He's a pediatric neurosurgeon with who's adapted any surgery, but his area of particular interest are tumor surgery, craniofacial surgery, a large practice as it's one of the national centers, and hydrocephalus. And he also has a big practice on pediatric Chiari with many secondary referrals. And he has been a very big supporter of our listserv webinars, and really great to have you, Mr. Shalindra Magdum. Thank you, sir.
Thank you very much, Naren. Pleasure to be academically involved on Saturdays. Really keeps your brain working. Otherwise, you are doing something which is probably, I would say, this is a much pleasurable way to spend your rainy afternoon in the UK rather than trying to do some work.
Thank you so much for being with us. Thank you. So the first speaker we have is Dr. Tobias Langheinrich. He's a consultant neurologist at Salford Royal Hospital at the Greater Manchester Neurosciences Centre. It's probably the largest neurosurgery neurology department in the country, and he has a huge practice of normal pressure hydrocephalus patients. He works in collaboration with the consultant neurosurgeons, and I used to be a colleague of his. It's a very nice practice that he has set up with the MDT focus, with the MDT clinics, MDT meetings, and a great very active in research, once again with the multidisciplinary research. So he's going to talk to us about differential diagnosis of NPH. This is a slightly area that neurosurgeons feel anxious because we just know our hydrocephalus, we don't know the neurology hydrocephalus, and sometimes we don't know what to look out for. So this lecture will be very insightful and would be a good reference to all of us. So it's a great honor and privilege to have Dr. Langheinrich join us and give us this lecture. Thank you, sir.
So thank you very much, Naren, for the invitation and the very nice introduction. I'd probably like to add that my main practice is really general neurology and cognitive neurology. So I came late to normal pressure hydrocephalus for a few years now, but a much longer practice in cognitive neurology. But I think that's making it so that's the bit I can sort of contribute to the normal pressure hydrocephalus world. Now, I've not ever given a talk to a surgical audience, so I hope that this is sort of well attuned and will be helpful. Don't want to paternalize anybody. There will be bits that probably you sort of feel, why is he telling us that? But in a way, because it's such a short 15 minutes, I have basically chosen to present the neurological approach and then highlight a few things, and then we can basically talk about this afterwards if there are any questions. So I'll just share my screen.
You can see it.
So is it in maximum size?
Yes, it is.
For me, it is. Yeah, great. Okay. So I've got 3 parts to it. An introduction, something in the UK we call surgical sieve, which is an anatomical way of basically not forgetting potential differential diagnoses. And then perhaps at the end, a couple of specific disorders that I want to highlight. Now, the relevance obviously is because normal pressure hydrocephalus differential diagnoses are most of them probably in the domain of neurology. Obviously, there are also neurosurgical ones, but many of them are in the domain of neurology. Now, the neurological approach, and I think it's not any different for the neurosurgeon, is the definition of the clinical syndrome, the phenotype. Now, there is probably a difference in that neurosurgeons can rely, due to the nature of their specialty, rely more on sort of macroscopic structural abnormalities. So, you need to see something on the scan. But I'd like to highlight that whilst hydrocephalus is a structural problem, it certainly can be mimicked. Imaging changes often are equivocal, and they may even be coincidental. So the neurologist is very much used to diagnose by history and examination, or history alone. A diagnosis of migraine is purely on history, so we're happy and confident with that. Now, what is this clinical syndrome? The pathology that's likely to be underlying the patient's problem corresponds very much to the time course. So that's why neurologists spend a lot of time trying to find out when things started, how they started, how long they've been going on for, and have they deteriorated or improved, or are they fluctuating? And essentially, if something has been going on for months to years, it's a degenerative problem, as opposed to sudden, you wake up, have a right-sided weakness, likely to be a stroke. In between, so days to weeks normally are infectious, inflammatory, or malignant disorders. So with NPH, we're really within the domain of degenerative. Sorry, I've gone quiet because it doesn't move on. I don't know why that is. No, sorry. So the symptoms and signs, though, they correspond to anatomy, and that will be important for the next slide. Now, neurologists work very much with diagnostic criteria. So these clinical syndromes, they have informed diagnostic criteria, and within those diagnostic criteria, there's usually a time course. So for the purposes of normal pressure hydrocephalus, it has to have been going on for at least 6 months, etc. There are core symptoms and signs. Now, investigations are always complementary. They're never the core symptom in neurological disease. They're usually exclusionary criteria as well. And then all this is stratified according to a probability. And this is informed usually by large clinical pathological studies, which is in a way a problem in normal pressure hydrocephalus, as there are no such large clinical pathological studies. Definitely requires always a tissue diagnosis. Probable is based on symptoms and signs only. So again, symptoms and signs, not complementary investigations. They are supportive. So what about NPH? NPH is a clinical radiological syndrome as opposed to a clinical pathological syndrome. It's a triad, and there's usually hydrocephalus on brain imaging. Well, not usually, there has to be. Now, if we define the typical clinical syndrome of normal pressure hydrocephalus, the usual time course is one of insidious onset and gradual progression, so it will mimic neurodegenerative disease. The usual sequence is that the decline in mobility is first, and it is followed by a decline in bladder control and cognition. The gradient is that usually mobility remains worse than bladder and cognition. And the nature of symptoms usually is a shuffling to magnetic gait, bladder frequency, urgency, or incontinence. They have a dysexecutive syndrome from the cognitive viewpoint, but there are also other presentations, ataxia, they can be Parkinsonian, they can have bowel urgency, incontinence, and certainly they can have cortical cognitive features. I will come back to that later. Now, the issue with NPH is that from my perspective as someone dedicated to cognitive neurology, dementias, atypical dementias, movement disorders, the clinical presentation is really very heterogeneous. Having said so, part of the reason is that we often go from scan to patient, then from patient to scan. The other thing for the field is that there are no pathological hallmarks. Now, for the next few slides, I'm mentioning bladder control here only once. In isolation, it's not considered here, even though I acknowledge that it may be the patient's most prominent symptom, but I would not build my differential on the difficulties and with bladder control. The sort of relevant differential diagnoses that are cognitive and affecting mobility, they in fact overlap. However, still, as I said before, mobility in isolation, but in particular cognition in isolation, is actually much less likely to be normal pressure hydrocephalus. And that's helpful when you prioritize your diagnostic probabilities. So to the surgical sieve, this is an anatomical approach. And with regards to gait, obviously, you can have non-neurological reasons for that, musculoskeletal. So one would inquire and examine for bone joints and tendons. People may have osteoarthritis. They may have a connective tissue disorder. With regards to the neurological part of the locomotor system, if you start most distally, people can have problems with their mobility because of a muscle disease, for example, inflammatory myopathies, but they usually cause pain and a proximal weakness. Neuromuscular junction is the next, purely anatomically, myasthenia is the common disorder, but this usually affects the small muscles of the face, so not usually causing a problem with differential diagnosis. The nerve, for example, the commonest is the diabetic neuropathy. People usually have sensory symptoms and on examination, low motor neuron signs. That's probably pretty frequent because diabetes is frequent, and it will sort of, which should be included in any formulation as to the likelihood of improvement, because it does certainly affect mobility. Root problems, I'm mentioning a surgical one here, lumbar canal stenosis. Again, people usually have sensory symptoms, including pain. Cord problems, again, surgical cord compression, but there are also sort of medical or neurological causes with a null MRI scan that normally should be picked up by finding a paresis, a spastic paresis in a sensory level. Now, the following ones, they can cause differential diagnosis difficulties, diagnostic difficulties, brainstem disorders, and I'm sort of talking about peripheral and central ones. They may present with a mobility disorder. So if you've got a vestibular problem, they may have other cranial nerve signs. Now, they should normally not have cognitive problems, so that may help. Midbrain is difficult, and I'm mentioning here that one at the progressive supranuclear palsy. So if there's one thing to take away from this talk, it's certainly this condition. Pyramidal system, it is again difficult differential diagnosis if it's subcortical. For example, cerebrovascular disease. I will in fact not really talk more in detail about cerebrovascular disease, even though this is sort of the probably most important differential diagnosis, but I would even go as far as there probably must be an overlap between cerebrovascular disease and normal pressure hydrocephalus, but it's very variable in its presentation and very hard to pin down diagnostically, really. If it's a cortical pyramidal problem, then we talk about motor neuron disease. Usually you can pick that up on examination. People have a mixture of upper and lower motor neuron size, and they basically become weak. Again, extrapyramidal problems, they are difficult to differentiate. Any cause of Parkinsonism, and it can be vascular, or it can be any of those neurodegenerative problems, Parkinson's, Lewy body disease, which in a way is the same underlying pathology in a different distribution, and the same is true for multiple system atrophy. The underlying pathology is the same in all of those. By contrast, PSP and corticobasal degeneration, they are so-called tauopathies, so they are pathologically separate. But all of those are essentially the mainstay of a requirement for differential diagnosis. Now, cerebellar disease is really only difficult if it affects gait only. Normally, cerebellar disease also causes problems with the upper limbs, with the eyes, with speech, and they don't have bladder problems or cognitive problems typically, so shouldn't be too difficult to differentiate. Cortex, so cortical diseases, they are difficult if they affect the frontoparietal cortex, and one of those is corticobasal degeneration, or atypical Parkinson's disease, basically. But again, usually people have other symptoms that may suggest why this is sort of not an NPH type disorder, but must be a cortical dementing disorder, neurodegenerative disease. Now, if you think in terms of cognition rather than gait, so you could sort of build your differential on, so if a cognitive problem is part of the presentation, essentially you divide this up into subcortical, cortical, and cortico-subcortical. So cortical subcortical typically presents as a so-called dysexecutive syndrome, and simply speaking, people are slow but accurate. So they try a task and they persevere with the task, and they take a long time, and their scores are normally reduced, but eventually they get there, and if they're given enough time, they actually usually, for example, remember. So compared to patients' Alzheimer's disease, for example, their scores on memory testing are not too bad. So usually they're complaining a lot, but the score is not too bad. And the Alzheimer's patient will not complain, but they are dreadful in the memory task, obviously in more advanced stages usually. So a typical subcortical disorder would be cerebrovascular disease, but again, PSP, what I mentioned before, the progressive supranuclear palsy. Cortical disorders, they cause typical sort of fancy neurological syndromes, amnesia, aphasia, agnosia, apraxia. I've highlighted apraxia because the cortical basal syndrome causes apraxia, and that may not only involve arms, it may also involve legs, and that's why people then may have difficulties with their gait for cortical disorder. I've also highlighted visuospatial, that's your Alzheimer's disease. So patients with Alzheimer's disease, they may not have amnesia, but they may present with a spatial disorder. And then typically they can't walk, but they usually also have difficulties with their upper limbs and in fact with their ability to see. So I highlighted Lewy body disease, LBD, and again PSP as cortical disorders. So you can see that PSP appears twice. Cortico-subcortical simply means that some of those disorders can have both. And again, Lewy body disease and PSP appear here. So it may not be as simple distinguishing those on the basis of this anatomical approach. Now, I mentioned that already. Other anatomical areas, no cognitive disturbance is expected. So in fact, the absence of cognitive impairment at all should make you sort of think, oh, is this really normal pressure hydrocephalus? Now, a bit on memory, because they're so ubiquitous, everybody complains of their memory. Crucial to have a sort of working knowledge about the fact that people can have an either inefficient memory, so this is the subcortical pattern, or they can really truly be amnesic, a cortical problem. The hippocampus is affected, with the difference being, again, the inefficient patient is slow but accurate, and you test them again after a delay, so 10 minutes later. And in fact, if you give them enough time and cues, so helped by cues, it's the recognition memory, it's not too bad. The cortical, the amnesic patient is usually quick, and they usually quickly learn, 7-item address, and then you ask them, after 10 minutes, and it's gone. And then you try to cue them, and it doesn't come back. So that's sort of on a quick way, a way to work out whether the memory problem is subcortical or cortical. Now I've picked out a couple of disorders, and then I will have finished. So the first one I've picked out is the progressive supranuclear palsy. And the reason is that it mimics and causes differential diagnostic problems actually for several reasons. These are the diagnostic criteria, so you can see what a challenge that is and why probably a certain personality type is sort of interested in sort of being a diagnostician. Essentially, these people have problems with moving their eyes, they are unsteady, they are Parkinsonian, and they also have cognitive problems. Now, they may have any of those or a combination of them. And what these, so to wake you up in a way. Let's have a look at, oh no, here we are. So please have a look at this. A patient is asked to look up and down, but he moves right and left. So he can't really move his eyes at all downwards. And then someone takes his head and moves it. And then they're able to show that the eyes can move down using the vestibulo-ocular reflex. So this is your supra. This is this vertical supranuclear gaze palsy. So if you have this, this is very, very specific for progressive supranuclear palsy. The difficulty is that this often occurs late, or it may never occur, and you only have slowness, so you can still look down, but it's slower. Or if it's even less, you may only see the patient sort of having quick sort of movements right or left, called square wave jerks. Eyelid opening apraxia is that the patient is asked to close their eyes, open their eyes, and there may only be a delay in opening them. But if it's severe, they may have to use their hands to open it. Postural instability, this is something that will mimic normal pressure hydrocephalus a lot, because typically the people do fall, and that may be sort of the presenting feature. So this criterion is immediately met. And if it's sort of less level, so this is the level of certainty at 1, O1, P1, A1, this makes your diagnosis very certain. The lower you go, the less certain it is, but still to be considered. So here you only have a tendency to fall when you do the pull test, or here you do the pull test and they do a few too many steps. This is your Parkinson's, akinesia. Now this is a sub-disorder where people only have problems with gait freezing. A2 means that they are rigid in their axially mainly, and A3 means they look like Parkinson's disease, really. Now, this is the second bit. Again, I apologize for this very full slide. Here it's rated for you, the likelihood that you have PSP. Definitive needs neuropathological diagnosis, then there's probable and possible. As I already said, P1, P2, this was your problem with falling. Parkinson NPH patients will fulfill that very quickly, or they may have Parkinsonian signs, a bit of a tremor, a little bit of rigidity or bradykinesia. So you then need the eyes. Obviously, if the eyes come early, it's an easy diagnosis, but often the eyes come late. And that's why this diagnosis specifically is often mistaken for NPH. Obviously, it may coexist, but that's another issue. One other disease that I'd like to show you is the Lewy body disease. So this is a Parkinsonian disorder. Idiopathic Parkinson's disease is, say, motor only. Dementia Lewy bodies is dementia only, and Lewy body disease is in between. For our purposes, we use those diagnostic criteria. Again, you've got core features and you've got supportive features. Core features are either cognitive, so fluctuating cognition, or visual hallucinations. And then I would like to show you this one. Someone asleep, having a sleep study. So asleep whilst it does that. This is your REM sleep behavior disorder. Usually you need to inquire about that, but if this is positive, then your suspicion should be very high that potentially there is a neurodegenerative disease incoming. Parkinsonism is another core feature. So obviously you may have Parkinsonism and REM sleep behavior disorder, and that will make your diagnosis as I show you. So again, the biomarkers are only supportive. You've got probable and possible, but probable is 2 or more core features. So if you've got Parkinsonism, REM sleep behavior disorder, then you score probable. If you only have 1 core feature, namely Parkinsonism or REM sleep behavior disorder, and you have a biomarker, you can sort of consider that too. So I've sort of run through that. and my first conclusion, in a way, I didn't even mention it, but I would always recommend in the practice of NPH to have a neurologist as part of the team. Now, ideally, in an MDT clinic setting, so whilst neurologists are usually involved, there's often no cooperation. And I find that this is a problem. If people are seen separately in one clinic and then the other clinic, then the confidence is sort of lost in dealing with the patients. I repeat again, the neurological approach is the time course defining the pathology and symptoms and signs defining the anatomy. Use your surgical CSF, particularly for the mobility. And then I talked about individual disorders, in this case, Lewy body disease and PSP. So thank you very much. I'll stop sharing now.
Thank you. Thank you very much, Dr. Langheinrich. That's an excellent lecture. And it's really useful for us to have this lecture so we can go back and if we don't have neurologists, then it does help. But if we have neurologists as well, we know what to ask neurologists or what neurologists are talking about. But if I now go to Dr. Palendri, Dr. Giorgio Palendri, could you make your comments and questions? Your area is one of your area of specialization is adult hydrocephalus, and any insights also from Bologna. Thank you.
Thank you. Thank you very much, Tobias. I think this was really an excellent lecture, and I thank you very much for being here with us today. I think that I completely concur with you that this is not a one-man show. I mean, IMPH is truly a disease which needs to be handled by a multidisciplinary team. And I think that you as a neurologist are at the very heart of the team. So I think this was a truly important concept. I would like to ask you, how do you manage when, unfortunately, IMPH as not only a differential diagnosis, as also comorbidities, neurological comorbidities. Many of the diseases you mentioned are also comorbidity in IMPH. How do you manage this kind of patients? I mean, a patient with IMPH with Parkinson, maybe this should be a part of a tetrad in the future. How do you manage patients with IMPH and AD? What's your attitude in your daily practice?
Yeah, so thanks for asking that, because this is really very much the core finding sort of an exclusive IMPH patient is almost like finding a needle in a haystack. So they usually have always something else wrong with them. And that's why I was also saying that this collaboration is so important. So if I send a patient to the neurosurgeon who also has a diabetic neuropathy and who also has a lumbar-canal stenosis and who also has diabetes, etc., they will never be shunted, understandably. Having said so, if the neurosurgeon understands that there is a medic involved who has understanding in these other diseases, one can usually find an approach which, though, is really very much a matter of discussing it with patient and relatives to make them understand that the probability of shunt response and how much and how long for, etc., is unfortunately uncertain. So in a way, all those patients should really end up in clinical trials to try and find out what's going to happen to them. Obviously, one learns as you go along, but it would be a better way organizing that formally. So we have sort of teamed up a bit in the UK, trying to look into setting up trials to answer also those other questions. And obviously, there is some information out there about a sort of complex NPH, basically. So the short answer back is MDT, very important for this.
Yeah, thank you very much for that. Okay, I would have another question for you. It regards specifically the role of diabetes in this patient, because you know, diabetes is a very common comorbidity. These are elderly patients. polyneuropathy is very common in these diabetic patients, and diabetes is also thought to be maybe a common factor in IMPH. So how do you think we can manage this patient with diabetes? Because I mean, the surgical risk is slightly increased. They have confounding factors. For example, they could have difficulty problems with the gait because of the polyneuropathy. How do you evaluate this kind of patients, and how do you select this kind of patients specifically to send them to the surgeon?
Yeah, so there are various sort of aspects to it. One aspect is to try and gauge how severe the neuropathy is. Partly you can do that clinically by just tapping the reflexes and assessing, you know, for a sensory level, not for sensory level, for how bad basically the neuropathy has spread. If I find it significant, then I tend to obtain EMG studies to confirm this. And I would certainly convey to the patient that I'm concerned that there is another additional cause for the difficulties with mobility. That, but I would at the same time have to say that there is really no way of being certain at the end of the day how much benefit they will get. Sometimes one is surprised that people who have a severe neuropathy on an EMG seem to walk pretty well, and vice versa as well. The other aspect was probably more sort of triggered by my surgical colleagues. Obviously, you want a patient whose diabetes isn't too badly controlled in order to not be too representing too high an anesthetic and surgical complication risk, really.
Yeah, sure. Okay, do we have any question from the chat box? No, I don't think so yet. I would have, okay, we have one from Sushil. Is a CSF drainage the best way to settle the diagnosis, in your opinion, Tobias?
So the short answer is no. So I think CSF drainage has a role to play. And I think that was also sort of a little bit the intention that I had when I sort of said about a neurological approach, that investigations for neurologists are really subordinate. I mean, they need to fit in, and hopefully they are part of a complete picture and point in the right direction. But not that you would hang your hat only on the results of any stress tests, really. If it's helpful if it's going the right way, but you may even make, you know, contradictory decisions, really, meaning, you know, that the test may show one thing, but you're convinced about something else.
Thank you very much. We have another question from Uday. Well, I think maybe we are a little bit out of the field here, but what is the role of flow studies in IMPH?
Yeah, so thanks that you just a bit out of the field. From my understanding of flow studies is that it's certainly helpful for if there's a concern about any obstruction. But my understanding is that there isn't really good evidence to support sort of a positive criterion to say this is IMPH as opposed to PSP, also just on the basis of flow studies.
Okay, I completely agree with you. Till now, they are not yet conclusive, even these findings. So we cannot really base our differential diagnosis only on the CSF flow studies here. I would have a final question to you, maybe a little bit intriguing. What's your relationship with the surgeons? I mean, how often is it that you contact he or she directly? Do you have the possibility, the chance to have a multidisciplinary team when and where the neurosurgeon is present too? Do you discuss cases together? What's your feeling? How could we improve this differential diagnosis, including the neurosurgeon in the team?
Yeah, I mean, all the time. I mean, on a not daily, but on a weekly basis, we meet. We may not meet face to face. So since COVID, obviously the remote meetings like this one And in fact, to discuss radiology, for example, that's very good. The neuroradiologist will be at the other end as well. We may have performed videos of patients that we can review online, but certainly it's direct and it's direct talking to them. So I frequently put patients on our NPH-MDT list to be discussed, and that happens once a week on a Friday. And I would strongly encourage it. I mean, it was really an eye-opener for me to see how confidence and management changes just because you communicate directly.
Yeah. I think that's very important. Thank you very much for your comment.
Thanks.
Professor Said, he does not want to talk about incontinence as a criteria. I think you said already something on it during your presentation, but maybe you should spend some minutes commenting on that.
Yeah.
Shalendra, is that your question? Your mic is mute.
Yeah, it is. I just wanted to know, has something changed since last time I kind of did some adult hydrocephalus?
Yes. No, I wasn't disputing that it's part of the triad or tetrad. What I was saying is if you sort of approach it differential diagnostically, then I don't have a sort of a surgical sieve that's based on the urinary disturbance.
Okay.
But that may be my ignorance. So, a specialized urologist may have means to sort of work from the basis of, I don't know, flow studies or whatever they do to sort of say that, it's more likely to be a CNS disorder. That was all I said. I did not dispute at all. In fact, I would always expect that people have, the more, and obviously that's sort of been proven anyway. A single symptom only of the triad is sensitive, but it's not specific at all.
Thank you.
Professor Kenichi Nishiyama, NPH is a big thing in Japan, and I know that you are a pediatric neurosurgeon, but do you have any questions to Professor?
Yes. Okay. Yeah. Actually, I sometimes doing the operation for the NPH. And thank you for the fantastic lecture. I learned a lot from you. And Japan has been actively promoting DESH and publishing various guidelines, as you know, and making it a hotspot for NPH research. At first, could you confirm the terminology first? I'm aware that lately, instead of saying INPH, we've been referring to it as Hakim syndrome when considering clinical conditions. Is that correct?
So I think, yes, there is sort of some controversy about the terminology. I'm used to using the shorthand of INPH to refer to a hydrocephalic syndrome, which is thought to be idiopathic. I'm sure it isn't. I mean, there is no idiopathic disease really out there. We just don't know about it. But idiopathic in the sense that there's no preceding disorder and that there's no obstruction there, and that it doesn't fit a congenital disorder. And in fact, this is entirely in keeping with the Japanese guidelines. So Hakim syndrome, I think people use it, but I'm not used to it. And it is though important. I think there is, in particular, the congenital ones and so INPH and what I often call LOVA. So I'm quite keen on trying to distinguish them because I think they are, for me as a neurologist who works with symptoms and signs, they're different disorders. People are different. They're younger. They've got different heads. And as such, I try to distinguish them, even though there's certainly, I think, a great overlap in the literature about people calling anything just NPH because it's communicating.
Okay, I understand. Thank you. And as I'm a neurosurgeon, when I see the patient with NPH, I check the gait disturbance at first rather than the cognitive function. So in the process of differential diagnosis from the perspective of mobility impairments, it is necessary to consider abnormalities outside the central nervous system, including myopathy. I mean, for example, the visual impairment or the vestibular function or so.
Yes,
Please comment,
definitely.
please.
Yeah, definitely. So that's why I use the surgical sieve. So I think that's very important to look at all of those. So the surgical sieve is a little bit trying to be sort of non-judgmental. You just sort of say, look, they can't walk, and we'll start from the base and sort of look at everything, even though the history would already very quickly suggest that they don't have any of these other disorders. But I think the help of the surgical sieve is just to not forget to think about things. And that's why, in fact, mentioned the Remsley behavioral disorder. Sorry, you were talking about gait, I know, but Remsley behavioral disorder is an item that is almost never volunteered by patients, which I know because I sort of have a practice in cognitive neurology. But if you get this single item of information, it's extremely helpful to, for formulating your differential diagnosis. So again, this is the surgical sieve approach. You ask for it, even though there's nothing in the story as such that suggests that you have to ask for it.
Thank you. Yeah, it's good. Finally, please some comment about the CSF biomarkers, because in the AD, the p-tau or the A-beta 43. So some other biomarkers in NPH is we know that. So please some comments about the biomarker.
Yeah, so I'm only used to using the ones that are sort of for us clinically available. That's amyloid tau and the neurofilament light. Now I have to say I've so far not been terribly surprised, perhaps because I've got a background in cognitive neurology. So there's usually a good correspondence between how people present cognitively and whether their essentially their Alzheimer biomarkers are positive. And so far, I've not had anybody who had, for example, just a raised neurofilament light, normal Alzheimer markers, and ended up having PSP. But then I have to say that overall, that this is rare. So I've just not come across it so far. I definitely think that it's very important to this field, and in the future this will be crucial and inform us about these differentials. Do we deal with comorbidity, and can we basically define it pre-mortem? There are biomarkers in Lewy body disease. They're not available for me clinically. So sorry, the DAT scan is, but not the what's it called? The CSF tests, like for the prion disease, RT quick. We don't have that.
Thanks.
Okay.
Thank you.
Thank you. Yeah.
Can I ask a question? Thank you very much, Professor Nishiyama. In terms of, when I saw patients with the NPH, it's obviously as a neurosurgeon, I wanted to be in the loop from the beginning to end. I did not want to just come as a technician. But obviously, it's very much a neurology disease that, it was great to have Dr. Langheinrich. And also I found it's also I'm dealing with patients with multiple morbidities. And whereas when you are doing a shunt in a pediatric patient, usually they are healthy patients and they recover well. Here, before you take the plane out to put the shunt, you have to make sure that the patient is actually at the best condition or optimized and nothing is missed, because last thing is that you take a patient to put a shunt when they have got high blood pressure, that diabetes, other medical problems, while they are waiting on the waiting list, you then find out they have got a brain tumor as well that has come up. So I know that nowadays everything is MDT. It has its positive, but it has negative. But do you think having a geriatrician or physician also on a MDT helps in, what would you say? Can I ask Tobias first and then to Giorgio? Thank you.
Yeah, certainly. I mean, having geriatricians involved, I think, is very important and helpful. As a neurologist, I'm not that used actually with sort of the geriatric side. Obviously, people with Alzheimer's disease are often elderly. Having said so, otherwise, neurology is actually a speciality that has many young patients, with MS, for example, epilepsy, etc. in particular, the sort of the frailty is really an issue. Perhaps not so much in terms of the diagnosis, but more in terms of really, are we doing them any good, offering them invasive treatment, or are we actually too judgmental, basing our decision on just a high frailty score when in fact, they may derive benefit. And for me, this is open. Yeah, so I would definitely say it would be good to have geriatricians involved.
Thanks. And Giorgio?
Actually, in Bologna, we have a geriatrician in our team, and I think that their role is fundamental, even for the diagnosis, even for the treatment, and even for the follow-up. Because here we didn't mention, because it was not in the talk by Tobias, the follow-up. But I think that speaking of IMPH patients, the multidisciplinary team is fundamental also in the follow-up of this kind of patients.
Thank you. Tobias, this is the last question. That's one for you for the chat box. So this is the last question. In terms of the differential diagnosis of failed shunt patients, in terms of your neurological sieve, as if it were, do you go through when you see a patient who's failed the shunt or has improved and stopped? Obviously, it might be the shunt problem, but is there any thoughts or insights for you to think that this might be a different problem, that the patient was shunted? Any thoughts on that? Because for me, the NPH is not a one operation thing. It's like any shunt patients. Once you do a shunt operation, you inherit them for life, and when they don't improve, you don't know whether shunt is not working. Just for the audience, that when you do a shunt in a child with a hydrocephalus, when the shunt doesn't work, the child is obviously symptomatic and acutely symptomatic, and the shunt is not working. Probably with the NPH is that you don't know whether it's a shunt unresponsive patient or shunt is not working, or there's another neurological condition. Any thoughts on this, Tobias?
Yes, absolutely. I mean, that's sort of a daily occurrence as well. Where again, I think MDT is very important, and as Georgia said, the follow-up is crucial. That there are members of the team involved who are able to pick up on follow-up whether something else may have developed. Now, if a shunt has failed, it always seems to me sometimes to be sort of not 100% certain, as different practitioners seem to be doing different things. But certainly I would always leave that side to the surgeon, to be convinced that the shunt system works. But I would certainly contribute to sort of say, look, the patient has in fact PSP, or at least has developed it, and that's the reason why they don't respond. There are difficult situations when it's not 100% clear, but again, in this situation, it's even more important that there is sort of MDT practice going on, because otherwise the patient will be left to be dealt with by someone that may actually not have the clue to the diagnosis, if you know what I mean.
That's brilliant. So thank you so much, Dr. Langheinrich. It's an excellent lecture, which I will, if that's okay with you, I'll put it on our YouTube channel, which will be a great reference to everyone. And we usually nowadays translate it into Japanese, Chinese, in Russian, Arabic, and Spanish. So I will get them done, and since you are from Ulm, we'll do it in German as well.
That's right.
Thank you.
Thank you very much for giving me the opportunity. It was a pleasure, really, having been invited, and it was great to talk to you. I have to apologize. I'm afraid I have to go because I have to take my daughter to a sporting event. So I will not be able to stay, I'm afraid.
That's fabulous, and I'll send you the recordings.
Thank you very much. Okay. Goodbye, everybody. Thank you.
Thank you very much. So the next talk or lecture really is from Professor Henry Schroeder. Professor Henry Schroeder, it's a doyen of neurosurgery. Once again, of all areas, in terms of endoscopy, he's synonymous nowadays with endoscopy. I had the pleasure of visiting Professor Schroeder now exactly 10 years ago. I went to Greifswald and I still remember it as fresh as yesterday, and saw him do a complex endoscopic operation. Yeah, he was actually using endoscopy to do MVD that day. And then I recorded lectures with him, and I hope I can share you that one. So I think you can see it. You can see that this was 9 years and probably 8 months or 7 months, and it has total of 17,000 views. So Professor Schroeder, that's quite a large number of people that who have viewed, and I find it very useful as a reference to go back. So it's great. Professor Schroeder comes from Greifswald in Germany, and Greifswald is a very, very historical department from a neurosurgical point of view. It was the first department, it was the first place to have had a shunt with a valve. It was by Erwin Peyer in 1907, one of the most famous neurosurgeons of the 20th century. He was a celebrity in Germany as well as around the world. He has got so many Peyer's eponyms for him. And he was so smart that what he did was he took the saphenous vein, and then he used that as the conduit, and he shunted the ventricle to sagittal sinus. This was back in 1907, and the patient survived for a couple of years, and he did the second operation as well. And when the patients passed away, the valve was still, the conduit was still working. And then Dr. Professor Peyer, he's originally an Austrian. He then moved to Leipzig. So it's a very important historical place, which is even enhanced by Professor Schroeder. So Professor Schroeder is going to talk to us about a very complex area. It's the aqueductal stenting and aqueductoplasty. So without further ado, Professor Schroeder, may I please invite you to give this talk to us. We are looking forward to it.
Dear Naren, thank you so much for the invitation. It's a great pleasure to be here. And I remember very well when you came to us, and it was Murphy's Law. That was interesting. We had an ETV, and one of my residents, he did not fix the mechanical holding arm very precisely, and it slipped out. And the next day, Naren posted, "Is the use of an endoscope holder safe?"
Did I do that?
But that's what typical Murphy Law. It never happened, and it will never happen again, because now I always look whether really the teeth are inside. But you remember this, right?
Yes, absolutely. But the patient was fine. It was very...
Fortunately, it fall out and not fall in. That was a good thing. But it's a heavy arm. The pneumatic Vitaka arm is relatively heavy.
Yeah.
And when then is something that's not correct, it can be really dangerous. So if you have a good guy who can hold the endoscope, of course, it's also good because it's a voice-controlled holding device, go left, right, in, out. That's what we use in the nose for the pituitary cases, of course, very well. But in the ventricles, especially if you have small ventricles, I always feel more comfortable when it I fix with a mechanical holding arm, because I frequently do surgery with a young resident who has no experience in it. And then you have to, of course, to be careful. Anyhow, thanks again for the invitation. Great pleasure to be here. And I really admire what you do for the neurosurgery community, and always think, how has he the time to do all this? When is he doing this? No sleeping, obviously. So I should talk about endoscopic aqueductoplasty and stenting. And oh no, I have to share first. One moment. I hope this is the right one. Or no, this must be the right one. Can you see it now?
Yes, yes.
Full screen?
Yeah, it is full screen, yeah.
And moving?
Yep, absolutely.
Perfect. So I must say I was a consultant to Karl Storz, but nowadays not so much, because they have problems with the medical device regulation. So they don't need much consultation, but they are working hard. They promised us that they will be back soon in the future with all the ventricular stuff and also for the skull-based stuff. But it's a really mess for these companies to deal with the medical device regulation of the European Union. that makes the life really hard. And it's a very, very bad situation because all innovation is stopped. They just force all power they have, and it's really expensive for them to get the CE approval. But hopefully they will do it in the near future. So history. Dandy was the first one, to my knowledge, who tried to make an aqueductoplasty, and he forced a rubber tube from a suboccipital approach into the aqueduct. He left it for 10 days, and then he removed it. But then finally he stated any attempt to restore the aqueduct finally failed, and then he developed the technique of third ventriculostomy, you know, first frontal approach was cutting off one optic nerve, and then later on he makes a subtemporal approach. And then he said that is much more reliable than to restore the aqueduct. And then Lexell was the first one who put a stent in, but the mortality and morbidity rate of this series was very high, so it was abandoned as well. And in 1993, Oka was the first who reported an aqueductoplasty using a balloon catheter. And I must say, Michael Garb also before 1993 tried aqueductoplasty, but he did not publish it. So he was in my place. He was one of the pioneers of neuroendoscopy together with Dieter Hellwig and Axel Panetsky. And we published our first paper about endoscopic aqueductoplasty in 1990. And I was really enthusiastic about it because with endoscopic aqueductoplasty, you restore the aqueducts, the natural CSF pathways. You have no basilar artery, which is close to you. You have no arachnoid adhesion, what you have frequently or sometimes under the floor of a third ventricle. So theoretically, this was a really, really nice technique, and I enjoyed it to do it. This was a Garb scope that we used at that time. Here is a Garb scope, here is a tube. And we have also used a flexible 2.5 millimeter in diameter flexible scope to inspect the aqueduct. The aqueductoplasty per se is performed in most cases with a Fugate balloon catheter, and you have to look very accurately at the MRI. The aqueduct is not always a straight tube, but sometimes it's curved, and then it's nice. Then you also bend the tip of the Fugate catheter to avoid puncture of the tactile plate. So what are indications for endoscopic aqueductoplasty? Of course, aqueductal stenosis. And the second indication is a trapped fourth ventricle. These are the both indications. So what is important to have before you start the surgery? Of course, good imaging. Besides the standard T1, T2 images, we always have an inversion recovery turbospin echo sequence, which shows flow as a black signal. And you see here in this aqueductal stenosis, there's no flow. So you know there is something wrong. And then we use the high resolution T2 weighted images. We have some Siemens machine. It's called KISS, constructed interference in steady state, but it can also be Drive or Fiesta, depending on the machine you have. But it's a high resolution T2 weighted images, which shows here's a bulging of the lamina terminalis, distortion of pituitary stalk, bulging of the floor, pre-stenotic dilation of the aqueduct, so all signs of hydrocephalus, which gives you a clue that it's really an obstructive hydrocephalus. So the entry point for aqueductoplasty is far more anterior compared to the coronal borehole that we use for ETV. So we come from far anteriorly. The best is at least 4 to 5 centimeters in front of the coronary suture, but sometimes depending on the hairline, we just place it at the border in the forehead so that it's for cosmetic reasons. If you have a bald head like me, then you have to take a wrinkle to place it anatomically nicely or cosmetically nicely. And then we go directly to the aqueduct, put the catheter in and dilate a little bit. We should not dilate as much as shown here in this schematic drawing because there's a central gray around it. So that's a typical case. We look with an endoscope. You see this is a posterior commissure. This is a pre-stenotic dilation of the aqueduct, and here's the membrane. When you go very close, usually with a 30-degree endoscope, in all cases we found a pinhole which is still open, which obviously prevented the deterioration of the patient. But this is all stenotic aqueductal stenosis. Then we come with a Fugate balloon, we dilate a little bit, and you see it looks like new. It's really a very nice atraumatic technique. Sometimes it's not so easy. You see, this is a lady with a typical 3 ventricular hydrocephalus. You see the bulging of the floor, distortion of the stalk, and you see here it seems to be a stenosis, but there is some flow. But here distally, very distally, there's another stenosis. So this, of course, is very difficult to reach when you come with a rigid scope only. You cannot come to here. So that's why in this case we use the mother-daughter principle. That means we introduce the flexible scope through the working channel of the larger scope. Here, when you go into the foramen, we always go back to see the margin of the sheath to make no damage. Here you see mammillary bodies. And then the endoscope is turned a little bit backwards. You see posterior commissure. This is a dilation of the aqueduct as shown on the MRI. And you see it's very difficult to see where do you go. That's why we take now the flexible scope. At that time, we had no tip on the chip, but the fiber scope. And here you see the first stenosis, which is really not very narrow. So we go easily in, then you have to bend the endoscope, and then you see the second stenosis here. There's again, this is a pinhole, which is still open, but this is all membranous aqueductal stenosis. And now we just push the endoscope through, ruptures the membrane, and you see here the core plexus, the fourth ventricle. When we go down to Majandi, which is wide open, you see here the cervical spinal canal. So this can all be done with the technique of aqueductoplasty. But here, of course, you need the flexible scope. It's very important that you go the same way out as you came in, with the same bending, to avoid damage to the aqueduct. Okay, here you see the mother-daughter principle. This is a view from the rigid scope. And afterwards, you see the good flow void through the aqueduct. And you see the distortion of the floor is reduced compared to the pre-op images. So it's a nice technique. Another indication is trapped fourth ventricle. Usually it occurs in patients who were shunted. This was an older patient, came later also with a shunt introduced. You see large enlargement of the fourth ventricle, but here's a very, very small membranous stenosis. So in this case, a retrograde aqueductoplasty was performed under navigational guidance. The endoscope is introduced into the fourth ventricle. And then we look here, this is a rhomboid fossa. And when you go up, you see here the aqueduct, posterior commissure. And this is a lucky case because it's a very, very thin membrane. Just the membrane is perforated with the closed biopsy forceps. And then a Fogarty balloon catheter is used to open this stenosis. And then you see the core plexus at the roof of the third ventricle. So this is an easy technique. And you see, this is a good flow void, reduction of the size. And I had the luck to see her for other reasons 14 years later, and you see, still open, no aqueductal reocclusion. That is, for trapped fourth ventricle, a rare occasion, but probably it was because it was just a membrane. What we do usually in trapped fourth ventricle is stenting, because there's a high rate of failure. When you look to the literature, the aqueductoplasty alone in trapped fourth ventricle is rarely successful. One example, 40 months old male, premature newborn, post-hemorrhagic hydrocephalus, typical history in these cases. And you see large fourth ventricle, but very narrow lateral ventricle, and also the foramen of Monroe, which are more on the lateral side, but I have no image here, was very narrow. So we have to decide how can we bring the stent in. There are two techniques which I use. One is I go through the working channel, and one I go aside. So in this case, I use the Lotta. This has a diameter of 6.8 millimeters. But I can take the ventricular catheter through the working channel of the scope. And if the foramen of Monroe is narrow, which is almost in all of these cases the case, I use this conical shaped trocar. This is introduced in the endoscopic sheath, and I have a camera, a 0-degree endoscope, and under direct view I can go in, and because of the conical shape I can dilate the foramen of Monro a little bit. This is the case. We look in, you see the cyclops ventricle, means there is no septum. Here's the fornices. You look to the left side, right side, you see here's the fornix, and you see the foramen is very narrow. When I go with this endoscopic sheath, I damage the fornix or the vein. So that is not a good idea. That's why I change now to the optical trocar. And then I can go in, and because of the conical shape, I dilate the foramen. This is the mammillary bodies here, posterior commissure, and you see some hemosiderine remnants in front of the aqueduct. And then here is straight. Foccati balloon is taken because the aqueduct is straight in this direction. It's perforated, and then carefully just inflate, not much, just a little bit. And then you can take the small scopes. They have a diameter of 2 millimeters with a 1.2 millimeter optic. You go in and can confirm you are in the fourth ventricle, rhomboid fossa, Luschke was visible. And then the stent comes through the working channel of the lotoscope. It's introduced. You have seen we make side holes here to communicate all ventricles with one catheter, and then you can connect the shunt directly to this catheter. And you see here's a side hole. The problem now is you have to withdraw the endoscope without dislocating the catheter. And then to confirm it's really not dislocated, I go with a small scope again into the ventricle to make sure, the stent is still in a good place. And then this ventricular catheter is fixed to a Bohr reservoir or to a shunt system. See the post-op MRI shows collapse of the fourth ventricle. It's another case, post-hemorrhagic hydrocephalus, VP shunt, as usual. You see a huge dilated fourth ventricle. And in this case, we use the little lotter. Of course, the ventricular catheter is not fitting through the working channel. So we have to place it aside of the scope. This is another technique. You see the difference between the larger lotter and the little lotter is pretty much. So we go in. We see here the frame of Monro. Now we have the little lotter. The little lotter fits in without the optical trocar, but I have control of the edges when I go in. Mesa intermediate is pushed backwards. And you see down here the aqueduct. This is a posterior commissure. Then I take the Bugatti catheter to open the aqueduct. I take an endoscope to inspect. You see the quality of the endoscopes is reduced. We have to replace it, but so far we cannot get it. And then I take the catheter aside, lateral to the little lotter. Then you have to bend the tip a little bit that you can go in. And then I force the catheter through the aqueduct aside of the little lotter scope. And because the ventricular catheter is too thick. And you see the side holes here. Bring it in. And then you have not the risk that you have a dislocation, of course. You see the catheter is here in place and connected to a shunt system and fixed with a Bohr reservoir. So these are the two techniques which I use. There's another case, also same history, severe retardation, unfortunately. As an isolated fourth ventricle, the previous institution tried to place a stent between the fourth ventricle and the subarachnoid space, but this was not working. When you look here, where is the aqueduct? Hard to define. But when you look to the coronal view, you see here is the bulging of the fourth ventricle roof to the lateral ventricle. And you see on the side, you also see it's a good place. You make a ventriculostomy between the lateral ventricle and the fourth ventricle. Or if you want, so it is it's the elevation of the tela choroidea from the ventricles. So you make an interventriculostomy. It's not an aqueductoplasty and not an aqueductal stenting. It's an interventriculostomy directly from this cavity to the lateral ventricle. And you know you have two layers here, which you should open, and there are a lot of vessels inside. But this is an alternative when you cannot reach into the third ventricle and make an aqueductoplasty. When you look on the lateral view and the coronal view, you see a direct way which you can achieve from the lateral ventricle to the dilated fourth ventricle. But the anatomy is very distorted. So navigation, of course, is very helpful that you find the way to the lateral ventricle where you have the thinnest part of this membrane to the third ventricle. So we go in here. You see here is a thin area. But navigation, of course, is very helpful to guide the way that you get not lost, because the anatomy is very distorted in this case. But here it seems to be a good place, not too much vessels. Then with the deck forceps, we open the first layer, which is the wall of the lateral ventricle. And then you see here the tela choroidea with all of the vessels. And we look for a place where we can make a fenestration, where we have not too much vessels. Bogadi-Ballon catheter is taken to open it. And then we can go. This is a guillotine knife, which can be taken to cut very safely, because you have not the blades of the scissors, which otherwise go in the depths. You see what's in between the branches and the knife. So we make a wide opening. And then we can go in with the endoscope. You see here is the ventricular catheter. We did not pull on it because it was very sticky. We just leave it inside, but you see the dilation of the fourth ventricle. And then we place again through the working channel of the Lotta a catheter in dilated fourth ventricle, and then we remove the Lotta scope. And again, you have to take care that you have no dislocation, of course. And you bring this out. Here we check it again. All good. Stent is in good position. So 3 months after surgery, you see a reduction of the size. And then he came 10 years later with a control because of shunt problems. But you see the fourth ventricle is pretty good drained. Very small, and the stent still in place. Okay, we have done altogether 34 aqueductoplasties. Third fourth ventricle, we have a little bit more. So it's an old evaluation. There were 8 cases. And in 20 cases, we had just an aqueductoplasty. In other ones, we start with ETV, and then we look to the aqueduct, and we make the aqueductoplasty. Of course, just one is sufficient. Makes no sense to take both, but it was in the initial phase where we tried to see whether aqueductoplasty will work or not. And this was an evaluation which we had initially with these cases. 76% improved, 21 were unchanged, 3 worse, and 4 of them underwent shunting. And then we make an investigation to the flow, and it shows that we could found, compared to healthy volunteer, we can restore with aqueductoplasty a normal CSF flow in the aqueduct. So it's very nice. So what we wanted to have is the natural restoration of CSF flow, and that worked very well. So we were very happy with this. In the TAP fourth ventricle, we had clinical improvement in 75, and in 7 of the cases, the ventricle became smaller, also quite okay. We had no mortality, but we had 2.3 permanent deficits and transient deficits. And we had one problem with this conjugate eye movements, because the surgeon you see here is not hitting through the aqueduct, but a little bit laterally. And this caused oculomotor problems. And we had diplopia, also because of inflation of the balloon, but this was temporary just. And we had one trochlear palsy because you see the surgeon perforates the tactile plate because this tip of the catheter was not bent. But unfortunately, just a temporary problem. And when we had one epidural hematoma, which occurred in this guy with high intracranial pressure just after the ETV because of the reduction of the pressure in the brain. It was also not a big problem. We just evacuated and was okay. And this was, you see, all the problems occurred in the initial experience, showing the learning curve of the aqueductoplasty technique. How to avoid complication? You have to look to the MRI to see the configuration of the aqueduct. The bending of the tip is in most cases appropriate to follow the course of the aqueduct. No laser, no monopolar, and we use rigid optics, and then inspection with flexible endoscope. What we initially had then, we had a high rate of restenosis. This was after a mean follow-up of 34 months. You see 40% already. In one patient, we had acute deterioration. This was the patient. You see here, typical pinhole. We make an aqueductoplasty, looks good, but then she deteriorated, and after 10 days, she had the restenosis of the aqueduct. And you see here, enlargement. She was really in a very bad state, almost comatose. And then we performed an ETV and an aqueductoplasty. And then, surprisingly, both stayed open. You see both, aqueduct open, ETV open. And then another investigation we did a little bit later. We had 7 patients with reclosure. One example, young guy, aqueductal stenosis. We make a restoration of the aqueduct. Looks very nice. This is the stage which he came. You see massive dilation of the aqueduct. Very bad shape, clinical. Then we make an aqueductoplasty. You see very nicely, ventricles came down. 2003, very nice. So 7 years later, looks very good. But you see here, obviously, another small stenosis started here. And then 2007, you see the bulging and the dilation of the ventricles. And then we performed an ETV, and now he's doing fine with wide open ETV, although this is occluded. And then we ask about our long-term outcome, and we try to reach all the patients. And we were able to get most of them, and we published this paper in 2018. So this were the 20 patients where we performed only ETV, only aqueductoplasty without any ETV. 3 patients were lost, so we had 17 patients. 11 became symptomatic, so they underwent ETV. Another 4 patients had the restenosis, but so far no problems. And only 2 patients we could see a good flow void. Example, before aqueductoplasty, after aqueductoplasty, very nice. 60 months later, again, reocclusion. And this was, of course, disappointing that we have this high reocclusion rate. And even after many years, it occurs. Very, very interesting and difficult to explain why this happens. But finally, we have to admit that Dandy was right when he stated this in 1920, that any attempt to restore the lumen finally failed, almost in all cases failed. And when you compare it to other patients with aqueductal stenosis, ventriculostomy, the reocclusion rate was just 5%. Aqueductoplasty was 88%. So this is, of course, a little bit disappointing. Question is why this happens. And we make, again, phase contrast MR imaging and measured the flow. And we could see that you have a much higher flow in the ETV than in the aqueduct. You see the flow was much higher, and here the stroke volume ETV was 96 microliters, and aqueductoplasty was 24. Maybe this is a reason that we have a better flow, a higher flow, but I think also the opening of the third ventricle floor is larger in diameter, and it's only a thin membrane. So I think when you have a tube, the risk of reocclusion is, of course, higher than in this small membrane of the floor. So our conclusion is, although that is a nice technique and I was really a fan of it, you have to admit that the restenosis rate after aqueductoplasty is much higher than after ETV. So for aqueductal stenosis patients, I think the treatment of choice is an ETV. Of course, when you see there is difficulties with the basilar, very tight space, of course, you can perform an aqueductoplasty. If you're in doubt that it will occlude, you could place a stent, of course, in these cases as well. But in most of my aqueductal stenosis patients, ETV is a very nice procedure, very easy to do, and with a very high success rate. And then when you have a trapped forced ventricle, it's advisable that you make an aqueductoplasty and a stenting, because the aqueductoplasty alone, again, has a high occlusion rate. So thank you again for the invitation. Great pleasure to be here, Larry. Thanks.
Thank you so much, Professor Schroeder. That was a masterful lecture, amazing experience. And as always, you are very honest. And I just want to, first of all, ask Professor Mr. Shailendra Magdum, your comments and questions to Professor Schroeder. Thanks, Mr. Magdum.
I kind of say it's a vast experience of doing those excellent cases with the equipment you have. Means this is something we aspire to have, and unfortunately, storage is not around. The equipment is not around to do what you do. And just a quick question is, when you get trapped fourth ventricles, which is going to be more and more common after getting the individuals who are premature with intraventricular hemorrhage and washouts done, and ultimately some of them need a shunt. Direct surgical tackling of the obstruction from the posterior fossa, or even using an endoscope through the posterior fossa. Have you tried that, and what success rate did you have?
No, we just usually come from above if possible, but when you see everything is very narrow, you can make a retrograde. But I've seen we have not much experience. We have, I think, overall we have now, I think, 14 or 16 trapped forced ventricle, because in my area we have not so many children. So we have not a high number which where I can compare it. But the cases where we done were quite successful. And the good thing is that we communicate every compartment with one catheter.
Yes.
And then you have a simplification of the shunt.
Thank you. Great lecture, great learning experience.
The problem for me is always, what is an indication? And then we rely, of course, of our pediatricians, neuropediatrics, and ask them, is there a deterioration? Is it really symptomatic? Because we have some patients, we have large trapped forced ventricle, but clinically it's not very apparent.
Yeah.
That is, for me, as an adult neurosurgeon, it's difficult to judge, is it really symptomatic or not? And then we trust, of course, our neuropediatricians. I mean, they say, yes, there is some problem, and it is fitting to the image that it's really a compressed brainstem against the clivus, of course, then it's a good indication to do it.
Thank you.
Thank you, Mr. Magdum. Professor Kenichi Nishihama, please, thanks.
Yeah. Thank you, Henry. Your presentation was fantastic as usual. So thorough that actually I don't have any question for your presentation, but I think we've learned your technical tips about the bending the tips of the catheter, or the confirmation of the location of the catheter after the insert and from with a small micro endoscope. You say the diameter is 2 millimeter.
Yes.
Yeah, and I wonder about that. If you know, please say that, do the drainage volume and velocity of CSF from the upper and the lower holes of the stent remain consistent if you connect the VP shunt to the stent? For example, in the isolated forced ventricular case.
So what, I don't get the question. What?
Sorry, if you connect the VP shunt to your aqueductal stent, in case of the isolated forced ventricle, do the drainage volume and velocity of CSF from the upper and the lower holes for the stent to remain consistent?
I don't know. We did not measure in the tube. We did
of course.
measured after aqueductoplasty, not with stenting. I don't know whether they can measure reliably in the stent the flow. Maybe it's possible. I don't know, but it's so narrow. I think that has a high inaccuracy rate, because when you see the pixels, how many pixels you have inside the diameter, I don't know whether it's working. No, we did not do. We just measured after aqueductoplasty and after cervical and there was a big difference. But in the stent, I have no idea.
Yeah, of course. Actually, I myself, my indication of the aqueductoplasty or aqueductal stent is only for the isolated fourth ventricle. As you shown, the ETV is better rather than aqueductoplasty.
I agree.
And,
I agree.
Yeah. Is it possible to consider using alternative materials for tube stents besides silicone catheters?
We take just normal ventricular catheters. Don't know whether it's better.
Yeah, the same as me. And I checked now in the chat box, and one question: if the VP shunt is already functioning, could lateral ventricle to fourth ventricle be a simple option?
Yes. When the shunt is still working, you can leave the shunt and make just the stent, but you should fix it at the Bocher reservoir. Initially, when Michael Garb was my chairman, we used 4 to 5 centimeter stents. And we had some patients, you see the stent looks very nice in the aqueduct. Then after, let's say 1 year, it was at the outflow of the fourth ventricle. 1 year later, it was cervical spine. And after 5 years, it was in the lumbar spine. So if you always fix it at the Bocher reservoir, and also if you have infection or something, it's easy to take it out. So always we take a long stent now.
I see. I sometimes use the same technique from parental approach. It's easy.
Yeah.
So thank you, and congratulations for your excellent talk.
Thank you.
Thank you. Thank you, Professor Nishiyama. Dr. Giorgio Palanderi, you have got questions for Professor Schroeder?
Yeah, thank you very much, Professor Schroeder. I think this was really impressive videos and impressive lecture. So thank you very much. I would like to ask you, based on your huge experience, in a case of aqueductal stenosis, so would you consider first ETV rather than aqueductoplasty, or vice versa?
No. As I said, first, always ETV, because you have seen the success rate in the long term is much better. But there might be a case where you open up the floor of the third ventricle, you see a lot of membranes, or you see it's very narrow, there's no space. Although I must admit, even in the posterior fossa tumors, you always find some space to make an ETV, in my opinion. So it is very theoretically. But if there would be a case where the ETV looks not good or it seems to be dangerous, of course, then you can try an aqueductoplasty. But in most cases, it's so nice, the third ventriculostomy, and you have such a good success rate that it's a procedure of choice.
And a second question, based always on your experience in a teaching hospital, what would you suggest to young surgeons as the learning curve of this kind of surgeries? What's the key point of these surgeries, and what would you suggest in steps to do for them?
First, learn anatomy. This is the most important, of course, because you see normal anatomy is easy to recognize, but sometimes in cases it's very distorted. So anatomy they should learn, and then of course endoscopic techniques. So I would advise them that they go for endoscopic courses to get some experience in the handling of the endoscope, and some training models are available for ETV. And then of course they should go to somebody who can do the technique, has a lot of experience to learn clinical cases, join them, assist them. And then of course, when this is done, they should start under supervision to perform an ETV. The ETV per se is easy. It's technically not a big deal, but a lot of mistakes can happen and disastrous complications may occur. And I know In Germany, at the beginning, when we started here with ETV, there were a lot of really fatal complications because of basilar artery injury, but nobody dared to publish it. We had one case where the surgeon went with the balloon behind the basilar, and then he inflated and then he ruptured a small perforator from the basilar, and it started to bleed massively, and he irrigated, it stopped, patient went to ICU, and then he rebled and died. But most of the cases were not published. But I know from lawsuits and from other information that there were several of these cases. So with an ETV, although it's simple, when you do not take in account what can happen and be careful, then it can be a disaster. That is the problem with this technique. So as you should learn when, how to do it, where to do it, and what is the right option to do it.
Thank you very much.
Thank you very much, Dr. Pandiri. On the follow-up, for endoscopists, at least from my point of view, doing an aqueductoplasty or aqueductal stenting is the height of neuroendoscopy, at least in my books. And I have seen, young neurosurgeons trying to do this as soon as they can to, enthusiastic ones. And what's the learning curve for aqueductoplasty and aqueductal stenting? I would like to know your thoughts, because I once spoke to Professor Andrew Groton-Hughes, and as you know, he's like you, an endoscopist in heart, and he said, Naren, do 200 ETVs before you go to do third ventricular colloid cyst. And I think it's important to look after the patient. So I just wanted to have your thoughts on the learning curve for aqueductoplasty. Thanks.
Now, I think it's difficult to say. When you say you need 100 ETVs before one aqueductoplasty, then I could not start that at that time. But I think you generally need to have skills how to operate. That is very important. And with aqueductoplasty, the problem is it's midbrain. And you have shown one case. There was an experienced endoscopist who did it, but he failed because he went paramedian, not through the aqueduct. So you have to be very careful. And sometimes the aqueduct stenosis is short, then it's easy, sometimes very long. And then you have to consider, is it really a good idea to make it? I think to see the indications, the most important thing is to see an indication, to see, yes, this case is suitable to do it, or not to jump on anything and say, I can do it. You must be very careful. It's very, very important. So I was an expert witness for one case where there was made an ETV and aqueductoplasty. But when you look to the MRI and the sagittal plane, you see there is almost no foramen of Monroe. So how can you go with a thick endoscope? And it was one of the thickest one. It was a CAMAT endoscope. It was very big. How can you go to both places? They went in, and then they ruptured the complete the fornix away, and then they punctured through the midbrain. That is a problem for an indication. You have to look at the MRI and see this is not a good case for this. Please take just a shunt. The shunt is not a shame. And that is the most important, that you really see what is the indication for it. Look at the MRI very precisely. I always teach my residents, please look at the MRI. Sometimes they say, yeah, we make an ETV. I say, no, it's not an ETV case. It's a biventricular hydrocephalus because of foramen Monroe stenosis on both sides. And that is what they should learn. And then, of course, the handling. But it's difficult to say we need, let's say, 40 cases ETV and then one aqueductoplasty. Maybe that is a good ratio, but it's a guess.
Thank you. And in terms of the endoscope, you mentioned you use the rigid endoscope and then to use the flexible at the end. Would flexible be a better choice for these, or rigid is better choice?
I think if you have a good flexible endoscope, good optical quality, of course, this can be done, and then you don't need a rigid one. But when you make just an aqueductoplasty and you have a straight path, I still prefer the rigid one because it's so easy to guide. and it's also nice. You can fix it in a holding arm. Then you have both hands for the aqueductoplasty, and you can inflate the balloon by yourself. You have an assistant, he can hold it. I think when you have a lot of experience, you can also do with the flexible, especially the chip on the tip, which unfortunately is not available in Europe. Then you can do it very easily, have a good optical quality. And Kenichi will confirm this because he has a lot of experience with this. There's no need for a rigid one. When you place a stand, of course, you have to place it aside of the scope, but it can be done the same like with the rigid one.
That depending on the anatomy. When you doing the aqueductoplasty, before that we examine the MRI and check the route to the. If you can use the straight route, I think that your rigid endoscope is the best option. But sometimes it's not straight, so I use the flexible scope.
Yeah, and Sunny Lam is also using the flexible now for all cases, I think.
Mm-hmm.
Yeah.
Thanks.
See, in Europe, we are not in a good shape because of our lovely European Union regulations. Very strange, huh? We could make gas sterilization. Why should we not use it? It's really, I don't understand it. It makes the life difficult for us. It's a pity.
It is a shame. Professor Schroeder, you have got a couple of questions on the box. One from Dr. Sushil Patka. Your comment about Lapras stent. Have you come across this Lapras stent?
Lapra?
Lapra, yes. Lapras, the L-A-P-R-A-S.
L'Excel stent I mentioned. What is Lapra stent?
I think I will ask Dr. Patka to. Dr. Patka, do you want to come on the mic or want to add some more to the chat box? While Dr. Patka adds, there's a question from...
Yeah, I'm on the mic now. Professor, Lapras stent was something that was used a couple of years ago, which had a kind of a flower at the end, so it would remain in place, It was passed from the posterior fossa. Basically, it was not just a simple tube, but it had a kind of, like a Foley's catheter, flower at the end. So once it was passed inside, that flower was helped to maintain it in position, and there was lesser incidence of migration, they claimed.
Ah, okay. I have seen one that was it was a little bit thicker from the beginning. So it was a small ventricular catheter and then becomes larger, and this was put autograde from above to down to avoid. Yeah, but we have never used it, so I have no experience with this. We just take in the regular ventricular catheter and then we fix it to a borehole reservoir to prevent this migration.
Okay, thank you.
Thank you. And there's a question from Jay Ju, what's your normal threshold value for CSF stroke volume across the aqueduct?
That is very variable. We measured a lot of patients, and it is interesting. It's extremely variable. You cannot see this is a normal value and this is a pathological value, because some patients with completely normal ventricle size have a very, very low flow where you would say, oops, this is an aqueduct stenosis, we should do something. In other patients, it's opposite. They have a flow which is larger, but still they are symptomatic. So the range, the physiological range seems to be very wide. That's why it's difficult to say. So we were not able to find and to say this is a normal flow that is pathologic. We just could compare the cohort of normal patients with the cohort of the aqueductoplasty patients, and we found that we have similar values. So we could restore the flow in the aqueduct. If you have no flow, of course, then it's a pathological value, but otherwise it's difficult.
That's great. Thank you very much, Professor Schroeder. Thank you very much for the question, Dr. George Usha. I have to mention that, for those attendees, that Professor Schroeder's contribution to not only neuroendoscopy, but education worldwide is just unbelievable. I think he's in the same category as the late Dr. Goodrich. I mean, he's taught every country, and certainly, he's a household name in Egypt and India, and he has taught. I mean, his contribution for teaching and is just amazing. It's it gives a lot of time, and and in the listserv, every time Professor Schroeder has sent an email, it has changed, immense amount in my practice. The last one was where I had a patient with once again a patient with a congenital hydrocephalus, and my neonatology colleagues wanted to put the patient to palliation, and then I sent an email as a last, and it was a whole Sunday we went back and forth, and then on Sunday evening I sent an email on the listserv, and I got a reply on Monday morning, or on the listserv Dr. Schroeder posted. I immediately sent the email and his case to my neonatology colleagues, and they immediately said, sure, we are not going to have MDT for palliation, and they changed it. So the mother gave me 3 boxes of chocolates. One for you. Thank you very much.
Thank you for your kind words, Naren. My pleasure.
Thank you. So it comes to my talk now. I'll try to share it. It's funny that I usually open so many windows that when I come to give my talk, are you seeing the actual screen, or are you seeing only part of my screen?
We see the presentation mode. The next slide is there, and it's not the right.
Okay, just a second, please. I'll just disconnect.
That looks better.
Yeah.
Thank you. Brilliant. Thank you very much. I'm going to talk to you about CSF dynamics in space and what's called the space-associated neuroocular syndrome. I've always been interested in it. I haven't myself done any direct studies on it, or I have not been to the space yet, but I like to think that this talk you will find many aspects that you will find it interesting, but also will be applicable to the non-space hydrocephalus. So if you look at the space, going to space, astronauts' life is a very dangerous life. In 1980s, there was a 1 in 10 chance that the crew might be lost. And it's quite a high chance, actually. And in 2010, it's improved to 1 in 90. But if you look at the commercial aircraft, the risk for them to lose the crew is 1 in 20, 1 in 12 million. So, as much as glamorous as to be astronaut, it's a pretty high risky profession. But as you will see, more than just the risk of the rocket, there's other risks from microgravity. What is microgravity? For example, when they go to the space in a shuttle and orbit, or when they are in this ISS International Space module, they can be anywhere from 120 kilometers to 400 kilometers from the Earth, and they still, the gravity works across the universe. So it's not that they are floating because there's no gravity in the space station. It's because essentially if you ever looked at the rocket, how it goes, it goes initially vertically and then starts to tilt, because they have to launch the module in an angle so that it goes around the Earth. And so the velocity of the International Space Station is 28,000 kilometers per hour. And because of that, what happens is that the module just keeps going around. What I mean by that is that if I take a stone and throw it, the stone goes up and then it comes down. But if I throw it with more force, then it goes further up and goes further horizontally and comes down. But if you are on the space and throw the stone at 28,000 kilometers per hour, what happens is that every time it comes down, it kind of misses the earth and keeps going. And obviously there is a pull from the gravity, and the space station comes closer to about 90 meters every week or so, and then they use the boosters to keep it back in the orbit. But because the Earth is in fact the space station is in fact trying to come to the Earth, it's actually accelerating down. Because there's a free fall, that there's this feel, and also people float. So it's not actually they don't have gravity. It's because the space module is on a free fall, freely accelerating down, but because of the speed it's still going around, that people feel microgravity. So how to mimic that in Earth? If you put a patient on a bed and tilt their head down and leave them for a long time, and that is a way of mimicking the physiology of what happens in the space. Because there's no gravity, or the effects of gravity is very minimal in the space station, what happens is the blood and the fluids all go into the chest, into the body, and so what you have is that there's less fluid in the lower limbs and there's more fluid in the upper part of the body. So that's why you kind of mimic that with the head down tilt bed position. And when you do that in these experimental patients, and then when you investigate them, then you find that there's an increase in the density of the brain tissue at the vertex, presumably due to edema, and decreased CSF around the vertex, and increased ventricular volume, and also the intraocular pressure also goes up by about 26%. So at the moment, this is the best model that we have. In future, they are trying to come up with some animal models as well. And the astronauts may be in space for a short duration of time or a long duration of time. The index paper that was published in the New England Journal of Medicine in 2017 had astronauts who had been on short duration was 16 of astronauts, and 18 with long duration. When we say short duration, we are talking about around 2 weeks, and the long duration, we are talking about 5 to 6 months. So what they had reported in that index paper is that when the astronauts were in short duration flight, there was no ventricular enlargement. However, when the astronauts had been on long duration flight, 5 or 5.5 months, as in the International Space Station, they had ventricular enlargement. Obviously, when we think about ventricular enlargement, we usually think as neurosurgeons, large ventricles, but I will come to that in a second. And but so they compared the MRI before and also the MRI that was taken after they had come back to the Earth. But I think there are certain parameters that you have to be aware of in this study. The short duration of, for those who were in the short duration of flight, the pre-flight MRI was 133 days before the flight. So we are talking about at least 4 to 5 months before the flight. And for those who were in the International Space Station, their pre-flight MRI was done over, well over 1 year and almost 100 days. So 1 year and about 3 months. So these MRIs were pretty well long before they actually went into space. So when we go further in this lecture looking at the changes in MRI, you have to have this in mind that it was not a immediate pre-op and immediate post-op. And when they came back, the MRI scans again, the ones with the shorter duration of flight, they happened on average 9 days later, so well after a week, and the ones from short duration happened on average 5 days later. So once again, these were not done immediately, and as you know from hydrocephalus work, ventricular size can change quite dramatically in different conditions. And here, when they say that the ventricular size had changed, when the ventricular size had changed, what they have given as a data is the difference, but they didn't actually difference between before and after, but not, they didn't actually give the actual values and before and after. And so we don't know whether there was actually a significant change in between the before and after in these astronauts. So just to clarify what I'm trying to say. So here they looked at the astronauts who were on a short duration flight. And in the paper, they have given what was the difference in the diameter of the third ventricle. They actually have given the difference, but what they haven't told us is that whether there was a significant difference between before and after. So once again, when people don't give you these data, you have to be wondering why they didn't give, whether there was in fact a significant difference in that cohort itself. And in the long duration flights, they once again gave the difference, average difference between before and after, but they didn't give any p-values, whether there was any significant difference between before and after in those astronauts who had long duration of flight. So once again, sometimes what you don't hear has more message. But then what they did was they compared the difference. They compared the difference in the anterior. They compared the difference in the diameter of the third ventricle, the change in the short duration and long duration, and then they said when there's long duration, there's a significant change. So you have to be careful when they say there's a ventricular enlargement in ventricles, they are talking about the change in the short duration flight, long duration flight, and comparing between those two, but they are not comparing what happened before and after for each group. For the ventricular volume, what they used was a algorithm, a software that was from Oxford. Oxford has a very productive MRI unit, and they have this software called fMRIB. It's a free software that you can download, and it basically allows quantification of CSF of not only the lateral ventricles, third ventricle, and the fourth ventricle, but it's all computer generated. And when they looked at the volume change, once again, they found that the volume change in the people, in the astronauts who had been on long duration flight were much larger than the short duration of flight. So this is on average that the volume in the astronauts in long duration flights increased by 10.7%. But once again, everything is in the detail. If you look at the astronauts in the short duration flight, the data that they used for that was this data where there were 16 astronauts who were in short duration flight, but they only had data for 6 astronauts. So that's quite a large number of sample that they don't have any data. And once again, not only that, you can see some astronauts' volume actually decrease and some increase. So once again, it's not a congruent picture. And this is, it should say, the long duration rather than short duration here. Here, the data was therefore 12 out of the 18 astronauts who were in long duration flights. And once here you can see the CSF volume was all positive increase in all those 12 cases. And this is once again summarizing. What I'm trying to show is that the data is from already the samples are quite small, and then the data to look at the ventricular volume had come from even smaller sample, and there was much smaller in the short duration than in the long duration. It's interesting that they have used this computer technique, but they haven't, used Evans index or several other indices for ventricular sizes, which we can easily understand. Once again, I think they could have used the algorithm, but it would have been good if they had also reported in Evans index. The only, once again, the fact that they haven't made it leaves one to wonder. And the only and so this is a MRI scan that they had published on the paper for the short duration. What you are seeing here is that you can see the CSF spaces before, and you are seeing CSF spaces after the flight at the vertex, and it looks pretty much the same. But here, after an astronaut with a long flight, you can see very open CSF spaces, and post-flight you can see the spaces are effaced, and you usually see in hydrocephalus, or those with normal pressure hydrocephalus see this pattern. And they had published very useful supplementary data. This is the paper. If anyone is interested, effects of spaceflight on astronaut brain structure as indicated on MRI. It's a multinational project, but mainly coming from South Carolina. So these are really nice videos that I have put as video 1, 2, 3, 4, 5, 6 is all as one video. But in this video, you are going to see the pre and the post sign MRI, and it's showing how the upward shift of the brain and brainstem. So let me see if this works, and it is. You see that? You see how the brain and brainstem are shifting upwards in this nice illustration after a long duration of flight. I'll just stop it and I'll run it again if anyone. So, if you have the PACS software available, you can do it for your patients as well. So the next one, let's see. In the next slide, they are showing very beautifully how the cerebellar tonsils are going up, and also the supravermian cistern is decreased after flight. Let me see. So have a look at both the supravermian space as well as the tonsils, how they have shifted up after and this is this video. They are showing the effacement of the CSF at vertex, and they are showing beautifully the compression of the cortical veins. Once again, this compression of the cortical veins, this narrowing of CSF spaces at the vertex is something that we usually look for in normal pressure hydrocephalus. Here they are, I haven't seen as beautifully these compression of the cortical veins as this video will show you. You see the cortical veins there, and you see how in the post-flight scans they have been compressed. Right. I think you have seen it now. Good. And in this fourth video, they are showing once again beautiful video of how the brain is crowding around the superior sagittal sinus. You are going to see the video of the SINE MRI pre-flight and now post-flight. Great. And in the fifth video, you are going to see the upward shift of the brain and the brainstem, and what they are saying, the rotation of aqueduct. Certainly there's a movement of aqueduct. I can't quite see, so-called rotation that could, what they possess might be the cause of the increase in ventricular size with decrease in the CSF flow through the aqueduct. I think that's a bit pushing it a bit, but it's a really nice video again. See the brainstem and the brain going up, and also the aqueduct also changing their angle. Good. And the sixth video is really beautiful, this one. It's showing the movement of the optic chiasm and the pituitary stalk being stretched. And once again, they are looking at the MRI before the flight, long duration flight, and when they come back from the MRI that was done with a SINE MRI. You can see how the optic chiasm is going, how the pituitary stalk is being stretched. I'll just show it again. And finally, well, two more videos with this one. And here, this is the ventricular enlargement that they are talking about. So it's very subtle. And the third ventricle is also getting large. And the final video, the axial of ventricular enlargement. Great. So in terms of the ventricular volume, in a paper published by Ombergen, they looked at 11 astronauts who had been in space, and in them the ventricular volume had increased, but 7 months after that, there was significant improvement after 7 months in seven astronauts out of the 11, but none of them actually came to baseline. So these are, it's not that once they are exposed to gravity, things in terms of at least the morphology that returns. And the other parameters that they looked at were the size of the central sulcus, and as I already mentioned, the upward shift of the brain once again, they found that when the astronauts were in the long duration in the space, that almost all of them, 17 out of the 18, had narrowing of the central sulcus, and almost all of them had upward shift on the brain in the MRI of the 12 of the 18 that they did. In the MRI, T2 MRI, they also looked for the other parameters, the calcarine sulcus, the supravermian cistern, width of the third ventricle, and position of the cerebral tonsils, the ones that I have showed you. And they used the SINE MRI to look for the brain shifts, and also for aqueduct or rotation, optic chiasm, and stretching of the pituitary stalk. They did lumbar punctures on 3 patients who had a papilledema or optic disc edema, and they did the lumbar puncture in 3 patients with that disc edema, but one of them had it 3 times. So the one that who had it 3 times, I'll come to that hopefully in the next slide. But the patients who had the papilledema, the opening pressures were 28 centimeters, 18 centimeters, and 21.5 centimeters. And they were done 12 days, 8 days, 7 days after they returned to Earth. Once again, there's quite a long time. And also, as we all know, doing a lumbar puncture, certainly 28 is high, no question about that. 18 is pretty much low, within the normal range. And the space authorities have now put cutoff as 25 as the threshold for abnormal. 21, it can be raised, can be who's doing it, how it was done. And in all 3 patients with this optic disc edema, there was central sulcus narrowing. And once again, you have to be careful, because not all the patients who had narrowing of the central sulcus and narrowing of CSF at the vertex and uplifting of the chiasm, they are all the ones that I have highlighted. Not only 3 had 3 patients, 3 astronauts had optic disc edema, but majority of those who had the same phenomenon didn't develop optic disc edema. So one has to be careful. It's not 1-to-1. There's a long list of differential diagnosis for optic disc edema. What we call papilledema is when we know that it's definitely due to raised ICP, but otherwise you can get say similar appearance with other conditions. These are very beautiful MRI scans. This is from papers that I thought will be useful for many of the delegates here to look at features of MRI features of optic disc edema. Here you can see that there's the protrusion of the nerve head, the optic disc, and I've just put a zoom, and you can see. So this is one of those things that you can pick up in the MRI. Not all of them definitely have papilledema, but certainly you can all get the idea. And then CSF along the optic nerve. Not all the time that when there are CSF along the optic nerve, there's papilledema, but when you put 1 and 1 together, you can suspect it. And here, once again, that you are seeing, you can very more prominent papilledema that you can see on the MRI scan, where the optic nerve head is going into the orbit. And the other thing is that you can actually look for the optic nerve sheath enlargement, both in the axial as also in the coronal MRIs as well. So it's worth keeping an eye on these things when you are looking at MRI scan. One of the more specific signs with a higher reliability for papilledema is what's called the optic nerve tortuosity. Usually there is a bit of a slack in the optic nerve because eye has to move side to side, so it can't be very taut. But when there's raised pressure, then the tortuosity of the optic nerve can increase. And usually when the tortuosity could be on the horizontal plane or on the vertical plane, and when it's vertical plane, there's more chance that there's raised pressure. And then you can also get what's called a smear sign when on T1, the fats seem to kind of obscure the optic nerve. So this is once again a good sign to keep an eye out for. How do you diagnose a vertical tortuosity? The interruption of the optic nerve out of the axial plane. So when you're looking at the axial plane, you don't see the absolute continuity, and there's an increased curvature also on the sagittal plane. And when you are looking at the coronal plane, then the two optic nerve are not they are not like mirrors. They have a difference in their trajectory, and also looking at the CSF around the optic nerve. So these are the ways to look for the tortuosity on the vertical plane. And here, once again, a nice MRI from a paper that I showed before, which shows not only the papilledema or the enlargement of the optic disc head, but you are seeing the smear sign where the optic nerve looks obscured, and the vertical tortuosity associated with it. There's also, you can very rarely get what's called the flattening of the sclera when the pressures are high, and particularly when the intraocular pressure is low as well. Here you can see the flattening of the posterior sclera. Also, you can pick out optic nerve head protrusion on a CT scan, but more harder on a CT scan. That was just the sides for you to have some useful tips. Brain changes in space flight. Other brain changes in space flight, in the study by Koppelmans, they found that there's a decrease in the volume of the gray matter in the frontotemporal area. And they also noted that there's an increase in the volume of the medial primary sensory motor cortex. They attributed this to plasticity. And the question is whether this could be the cause for the effaced central sulcus. But usually this is about 1 millimeter. And so it can't quite account for the central sulcus effacement that was noted on those astronauts who were on the long duration of flight. The authors of that paper put forward a hypothesis: the distortion of the cerebral aqueduct might be cause of the ventricular enlargement. I wasn't quite convinced with the amount of aqueduct distortion that I saw on those video that they had. Other clinical features, interestingly, though these astronauts might have had, as you will see, that visual problems in terms of their long sight, but they did not have any other signs of high pressure that we associate, such as headache, vomiting, or cognitive function. In fact, that was the case with the other studies, but in this study, they didn't even mention that. So not having mentioned, one can only presume that they did not have it. There was another paper that was published regarding the ventricular size in astronauts. However, that was retracted. That's not available anymore. That was retracted by NASA for security reasons. So I'm going to go through in the last part of this talk on the space-associated neuroocular syndrome. So this is a syndrome, a visual problem that is seen in astronauts, particularly those in the long duration flights. And this is where the most of the research is concentrated on sands, and the question whether it's due to raised pressure is the secondary question, but where the money is on the sands. It used to be called visual impairment and intracranial pressure syndrome. However, this term was discontinued because it was not clear whether the visual problems were due to raised pressure or not. So since this had intracranial pressure, that was left, and then space-associated neuroocular syndrome term took over. The features of this are, as we already said, the optic nerve head elevation, or optic disc edema, and hyperopic shift. That's basically the long-sightedness or far-sightedness get worse, because it's presumed that there's a flattening of the sclera in the back that makes the eyeball smaller, and this makes the far-sightedness worse. As I said, the globe flattening, choroidal and retinal folds. So these are basically, you have got the retina, and underneath the choroidal layer, which has the blood vessels. And when there's an obstruction to the axoplasmic flow in the optic nerve, you get folds forming within, and so that kind of transmits the pressure, and you get folds forming in the choroidal layer and in the retina. So that's what this choroidal and retinal folds mean. And as we said earlier, there's increased CSF volume in the optic nerve sheaths, and also in these patients with these sands, there's been also ischemic retina noted. And these features can last for even up to 2 years after coming back to Earth. However, these patients don't have any diplopia, any visual obscurations that we will note with any IAH, no headaches, and there's no empty sella turcica, and no transverse sinus problems. The only risk factor that they have found is if the astronaut is over the age of 40, and when they go to the space, they are given a special glasses in anticipation of worsening long sight. There are many, I previously put a differential diagnosis for papilledema, but there are other causes of papilledema which can be radiation associated or neuroocular changes. So certainly when you are in outer space, you are exposed to a lot of radiation from the cosmos. And of course, what we want to know is that whether it's anywhere related to IAH, but it doesn't look like that. And this is what I mentioned in the paper. They did lumbar punctures, and they did lumbar punctures in 4 people, but on one person they did lumbar punctures 3 times after he came back. And 12 days post-flight, his pressure was 28 centimeters of water, 19 days after 21, and 66 days after 22. So looking at this, that the pressures are raised, and pressures are raised even after coming back for 2 months. And the NASA now has 25 centimeters of water as the cutoff, the LP for raised pressure. And this is with the legs stretched out. The changes in the globe, as I mentioned, there can be posterior flattening, or there can be increase in the size of the choroidal layer and retinal layer from edema, and that can lead to a decrease in the axial length of the globe, or in 3% of the patients, anterior chamber depth can also decrease in size. The hyperopic shift, that's the worsening of the farsightedness, is also still seen even 1 year after they have come back to Earth. The possible pathophysiology could be raised intracranial pressure. There are certain MRI findings that we saw suggest that the pressures might be high. The LP also pressures seem to be high. The other hypothesis, that compartmentalization of CSF to the area behind the globe, whether there's a kind of a one-way valve where the CSF comes into the optic, around the optic nerve, around the back of the globe, but can't go out, particularly when these brain and the chiasm go up and down, whether that can create a compartmentalization effect. There's a paper that has shown that this lymphatic system, the lymphatic drainage of CSF, that's impaired even after short-term tilting of the head down in the head down tilt experiments done on Earth. So this is not shown in astronauts, but if the head is kept down, it seems that the gravity effect of the gravity has causes impediment of the lymphatic drainage. Poor sleep and hypercapnia. Certainly, the PCO2 in the space station is higher, and when you breathe, because of the microgravity, the CO2 actually doesn't go away. It basically hangs around your face, and so now they have the NASA has tried to make the PCO2 level in the modules lower. The other hypothesis that was put forward by Dr. Satish Krishnamurthy that we know from the listserv and his colleagues is whether the macromolecules don't get reabsorbed and that causes a osmosis gradient and causes most interstitial fluid to go into the ventricle. As I said, the increased ICP, the possible mechanism is increased ICP. For increased ICP is microgravity causing blood to move to the upper body from the lower limbs and the lower body, and this causes increased venous outflow resistance because there's more blood in the chest area and the neck, and this causing increased intracranial venous pressure and decreased CSF absorption. The compartmentalization of CSF and globe and optic nerve, I previously mentioned it. Once again, this is a nice illustration of the possible mechanism is when they are in long duration flight, there's an increase in the intracranial CSF because of the shift of the fluid, and you can see the green is pre and this is red is post. And once again, you can see the increase in the size, so very difficult, but certainly there's CSF around the optic nerve, and you can see the flattening of the globe and whether that's contributing to this SANS syndrome. In terms of the technology, how to do these studies in the space stations, since 2013, they have got an in-flight optical coherence tomography to scan and send back data. And also there's a portable auto refractor to see whether the eyesight is, the long sight is getting worse. Also, they are now developing ultrasound to do lumbar puncture remotely from Earth. So it's kind of a robotic system. But obviously, you know, it carries a lot of risks, and also in-flight 3D ultrasound. Prevention, putting cuffs in the lower limb, also putting what's called the negative pressure suits. So what negative pressure suits does is it creates a negative pressure in the lower limbs and lower part of the body so that blood comes down into the legs and the lower part of the body, decreasing the amount of blood in the head and in the upper chest. Artificial gravity, once again, this has not been enacted yet. This is basically like a centrifuge, but it's a small centrifuge that you go and sit, and then it goes around and round and causing but here the leg, here the head is head will be towards the centrifuge so that the fluid goes to the legs. Apparently, swimming goggles can increase the intraocular pressure by about 1.9 millimeters of mercury. The idea is that to increase the intraocular pressure, so there's less of the effect of the intracranial pressure causing flattening of the posterior part of the orbit to cause worsening of the long sight. As I mentioned already, the decrease in the CO2 in the space station and try to reduce exposure to radiation. So at the moment, the only treatment is refractory glasses. That's good enough, but the problem is that if you are going to send people to Mars or to put stations in the moon, then it's important to try to work these out before you can plan the long projects. So thank you very much for your kind attention. I hope you found it's interesting and some useful points. Thank you.
Thank you very much, Naren.
Thanks.
I think you did really a great job.
Thanks.
I'm not really an expert in this field, but it comes immediately to my mind when I hear you talking of these topics, how important is this theory of the neurofluids and how much we still ignore of the whole process from which the neurofluid is born and then maybe circulates, maybe not, and then is reabsorbed and so on.
Absolutely. I think the hope is that not only that the studies for these astronauts will help the astronauts, but we might get some clues as to IIH or NPH, and certainly the videos that they had. Certainly next time I look at NPH patients, I will certainly have a different eye to looking at where the optic nerve is, the size of the pituitary stalk, the cortical veins, and so there, and also the MRI features of the papilledema. I thought that we can use in the day-to-day work as well. Thanks. Any other questions?
And Naren?
Yep.
Yeah, thank you. It's an incredibly important topic. If I want to know that I'm wondering about the physiological characteristics for the suns that create greater sun risks. For example, is there a correlation between the duration of stay in microgravity environments and the severity of suns? Some data about that?
I think there's no, in terms of the data, they haven't put any correlation. They have only compared between short and long, but they haven't correlated the duration of the long with the degree of SANS. I think there are two things. One is that only 12 astronauts that go to space every year. So that's a small amount of astronauts. But also, I think the data is also because of national security, or the space race is where every little matters between different countries. So I don't know how much of the data that they are putting out, because when when you read these papers, there are certain holes, but you would expect when they report, they usually would have it. So the answer to you is that at the moment there's no data correlating the SANS.
I know. Thank you. Maybe there are many questions that are being discussed with NASA. It remains under active investigation. Thank you very much.
Thanks.
I have a question. I get to what has been shown on the MRI, that it looks like there is increased pressure. Now, whether that is related to the altitude and hypoxia, similar to what people climb Everest and go to higher altitude. Now, is there a correlation that this study and someone who has climbed from, say, sea level to about 4,000 meters in a couple of days and see what changes happens? This is coming from a personal experience recently. I hiked in Nepal and flew directly to 3,000 and then went to 4,000. And overnight, I developed severe raised ICP symptoms, which I could tell that I was having significant amount of ICP. Lie down flat, gives headache, and then I had to hyperventilate and take some acetazolamide to sort it out. So if somebody had scanned me at that time, there would be definitely digestivity of the brain and all the changes. So I'm just kind of correlating to say that maybe there would be worth to look at the studies done for people who climb the Mount Everest, who, especially the Nepalese, who have got a different kind of physiology, short people high hemoglobin content, very much high concentration of hemoglobin. So it would be worthwhile to kind of look at people who live at high altitude and see what their brain looks like.
I think you are right. I think you make a very good point. Is that they are not only usually that they are on space stations, but their pressures in the
Yeah.
space station might not be the same as atmospheric. So it's not necessarily microgravity, but it might be a sub-atmospheric pressure as well. And in long term, obviously, as you said, that the mountain climbers and yourself experience those things. So you might expect those to certainly come up as well. It's worth exploring.
I think that would be a very good study, because that is more people I've seen. In so many Europeans come there on a regular basis, climb up to Everest base camps, which is about 5,500 meters high from a flat country such as UK or Netherlands, and they would be ideal candidates to study that.
I think you are in the right place, Mr. Magdum in Oxford, and the only thing is that if you propose this, you'll immediately get money from NASA. So it's one of those one of those researchers that you can.
I just need people to do that stuff. Work.
Absolutely. Thank you. So if there's any other questions, let me know, email me, but I'll make it available. But I thought it was very interesting to know what, we usually don't think about these things. Certainly it didn't come up to me for a long time, but it was always nice to know what happens to the CSF. I think the nice thing about CSF is that, if I were to do a skull-based meeting or skull-based webinar or a vascular webinar, after 2 meetings, I think you'll be back on the repeats.
Yeah.
With the hydrocephalus.
Yeah.
There's so many different things, and it appeals to everyone from hydrocephalus, pediatrics, skull-based. So this gives me. I just want to thank all the participants who joined and to our eminent faculty for taking time, and it's really, I think it's important to for our own brains, as Mr. Shalendra said in the beginning, to talk to each other. And then in an academic meeting, when we go to conferences, the presentation come and go before you think. And it's good to exercise our brains as well. And thank you for your time and your expertise. And so Shalendra Magdum, thank you very much, Professor Nishi.
Thank you.
Nishiyama, thank you very much, Professor.
Thank you. Thank you very much.
Very great. And to our great speakers, I think we had 2 fantastic talks from Professor Dr. Tobias Langheinrich, which will be probably one of the most looked at videos, because I always, whenever I try to do a video for YouTube, I do something on ICP, or I do on something Cobb's angle, or on pain. And mine, one on pain circuit, it has got 60,000 hits, because I know they are basic and it will have more hits. And certainly the one from Dr. Tobias Langheinrich on the differential diagnosis of NPH will be well looked at. And thank you very much again to Professor Schroeder. It's so nice to meet again 10 years time. And your 17,000 will grow and grow. I think endoscope, as you said, once people, or Professor Sinali said, people don't go to microscope courses, but they always go to endoscope courses. And I have used many times to just have a look at it again. And your talk on this aqueductplasty and stenting, which is a high expert lecture, will be very much valued. Thank you very much all, and wishing you a lovely rest of the weekend and the evening, and to see you all soon at the next meeting. Thank you.
Thanks for the invitation.
Thank
Thank
you
you very much.
Thank you.
Thank you, Madam.
Bye-bye.
Bye. Thanks.
Have a good day. Bye, everyone.
You.
And goodbye.